Hello everybody, and welcome to our presentation today on Pharmacy First. This particular presentation will be on impetigo, which is a core condition that pharmacists are expected to manage within the community as part of Pharmacy First. As always, an introduction to begin with. My name is Dr. Mohammed Omaji, and I am a medical doctor based in general practice as well as in accident and emergency. And I'm one of the co-founders of Pareto Education. We are, of course, a education company that specializes in the education and upskilling of the MDT throughout the country and beyond. We work extensively not only with individual practitioners, including pharmacists, advanced clinical and advanced nurse practitioners, physician associates, paramedics, and others, but we also work with organizations to provide training in order to upskill the clinicians that they have on their books. We try to address relevant clinical matters that really do affect patient safety and patient well-being. We lecture on a wide variety of subject matters from medicine and surgery, not only ourselves, but we also have a vast network of clinicians that we bring on board to provide expertise as and when needed, depending on the subject matter. Our education principle is based on the Italian economist Vilfredo Pareto, who defined that if you are to explore and learn the core 20% of any discipline, you should be able to reap 80% of the reward. And for this reason, we pride ourselves in concentrating on fundamental topics, explaining things from a pathophysiological and an anatomical principle, so that we're able to produce and help educate clinicians who are malleable and are able to adapt to the demands in the current health service. We have a number of different outlets, including social media, webinars, we do face-to-face seminars, and we have lots available for all types of clinicians looking for various different CPD development. Today's short lecture will focus on the following subject matters. We're going to start off with general principles, and then we're going to be talking about the features of impetigo. Then after that, we'll think about the other possibilities that a diagnosis or presentation may offer by way of diagnosis. So impetigo may not be the only option, and when to potentially refer. We'll have a discussion on antibiotic therapy, which of course is the mainstay of treatment for impetigo, although there are some options you can use before that, and then subsequently safety netting and when you might need to refer on to either the general practitioner or even sometimes to the hospital. Now, when we do look at patients with impetigo and we follow the Pharmacy First flowchart and guidance that's been given to pharmacists, we find that the inclusion criteria as part of this PGD is specifically non-bullous impetigo. This is specifically for adults and children aged over the age of 1 year and over. The reason why we say that is that children who are under the age of 1 shouldn't necessarily be getting impetigo around their mouth. They may get, for example, what we call baby acne, or they may, for instance, get a milk rash, for example, or even a teething rash, but impetigo is relatively rare. And children who do have a rash under the age of 1 could point to some form of immunosuppression. So this is why this is best left to community patient-facing clinicians who look at rashes on a day-to-day basis. The exclusion criteria is bullous impetigo, which means blistering impetigo, and of course, recurrent impetigo, both of which are complicated versions of quite a simple infection, impetigo, which we can manage in the pharmacy. And of course, patients who are pregnant, because there's all sorts of implications that may be present during pregnancy. Any patient that doesn't fit the inclusion criteria should automatically be referred on to their general practitioner. Normally, pharmacists do have some form of direct line with their GP if they are connected to a particular practice. And if this isn't present, then this should be ensured in order to allow for quick assessment if required. Now, the skin itself is a very interesting organ. It's the largest organ within the body, and it's separated into three distinct layers. You have your epidermis, and you have your dermis, and you have your subcutaneous fat. The majority of pain receptors lie within the epidermis, whilst many of the glands that secrete things like sweat and sebum, they lie within the dermis and also the subdermis, or more particularly the subcutaneous layer. Impetigo itself is an infection that affects the epidermis, so the most uppermost aspect of the skin, and it's highly contagious. It's a skin infection, and it can spread from a particular point to surrounding the mouth. It normally does focus itself around the mouth itself, which of course is full of quite warm saliva, especially in young patients, and this forms the perfect environment for the growth of these bacteria. It produces this characteristic honey-crusted erosion, which makes it quite distinct from other skin infections such as cellulitis. Typically, it's caused by skin bacteria like Staphylococcus aureus or even group A streptococcus from the throat. Now, because impetigo is highly contagious, it can also spread through direct contact. So patients should be advised not to share towels, especially if they're about to embark on a course of treatment for impetigo. It is suggested that once patients have impetigo once, it may be that they're less likely to get it in the same place, but that doesn't necessarily mean that they can't get impetigo elsewhere. So even, for example, if somebody has impetigo around their face, they can, for instance, get satellite lesions developing in other places if they are to have some form of contact with the lesions around their face. So hygiene is probably the most important aspect of conservative management in the first place, if you're sure that this patient has impetigo. The signs of symptoms of impetigo are redness to the face, the honey-crusted lesion around the actual area that's affected. Patients may even have some form of itchiness, and they could feel quite sore. Ensure that they don't have any blistering within their mouth, which may suggest an alternative diagnosis. Of course, bullous impetigo itself would require further referral, and it may be that patients refer to some form of leakage around the mouth or from the site itself. That's relatively normal. So please do tell patients that that can be expected, especially whilst they have this acute infection that's going on. Now, once we've identified a patient with impetigo, and we're going to be sharing some pictures shortly, especially in patients of darker skin tones, and there's very little imaging there, but in Pareto Education, we do believe in fair healthcare, and in the modern NHS and of course the modern UK, we have people from all sorts of backgrounds and racial groups, and therefore identifying skin infections is imperative in various different patient groups. So once we've identified that somebody might have impetigo, we need to make sure that we're clearing the PGD checklist. Does the patient typically follow the progression of impetigo? For example, the initial lesion is superficial with a gold crust and erythematous base. There is some form of drying of this lesion, so it's kind of wet in some places as well as dry in others. The lesion can develop anywhere on the body, but of course the skin of the face is the most common area, and satellite lesions may develop elsewhere. All of this is really keeping in contact and also in keeping with impetigo infections. Now, with regards to non-bullous and bullous impetigo, the main difference is the blistering. And we mentioned this because it's important to know that as pharmacists, as part of the Pharmacy First program, you should be referring bullous impetigo. Non-bullous impetigo is the most common form of impetigo, and it's kind of what we've been speaking about so far. Whilst bullous impetigo is less common, it's characterized by large fluid-filled blisters that pop on even the most smallest amounts of contact, really. They ooze yellow fluid, they can be very itchy and sometimes even be painful. These patients are at risk of having significant systemic complications, not only with satellite lesions, but of course with the fragility of these blisters, they could even get more severe infections on the skin and beyond. Here are some useful pictures of bullous impetigo, of course. As you can see, you've got some fluid-filled blisters on both of these patients. It's very widespread, so of course beyond the face itself, and it can cause significant complications. On lighter skin tones, we've got an example of this is non-bullous impetigo. So you can see the golden crusting around the face with some erythema or redness around the base. And in the second patient here, you've got, for example, the lesion once again, the gold crusted lesion with some erythema around. Patients in darker skin tone may look slightly different. You can see that the golden crusting is a lot more pronounced in this patient in particular, surrounding the mouth and also the nose. And it can also be a lot less pronounced in patients with darker skin tone, especially if erythema is the main form of presentation of their impetigo and if there is no golden crust. This patient probably has impetigo at a little bit of an earlier stage. The crusting does eventually get worse, and that's where most people identify, or most clinicians identify patients to have impetigo. And here you've got very little crusting. This is probably the last. This is the earliest stage of impetigo with a pink erythematous base, which would eventually develop with more characteristic features of impetigo. Now, it is a clinical diagnosis. You can potentially perform a swab. Now, in pharmacy, this may be something that you may not be tempted to do, or you may not have the infrastructure in place to make that request. But once again, if you're unsure of the diagnosis, you should not be treating them blindly. Rather, you should be referring them upstream to the general practitioner who may be able to better investigate these patients via a swab, for example. Please do consider the risk of deterioration in these patients. Now, this patient or these patients may have quite a localized infection, which may subsequently get worse quite quickly. If a patient is immunosuppressed, you should be incredibly careful. You should ensure that you're taking a good history about the patient's past medical history. And if they are immunosuppressed, then you may consider upward referral or upstream referral. And of course, do safety net patients for severe complications, particularly of surrounding or worsening erythema, indicating cellulitis, and of course, systemic features of sepsis. You can also consider calculating the NEWS2 score. You should all be trained on how to take normal observations. So it's important that if you are suspecting that this patient is unwell, then you do some observations to help your upstream referral if required. Now, the patient may not follow the typical progression of impetigo. If, for example, they've got ulceration or even blistering of the site or the area of infection, if, for example, there is blood that's coming out of this site, for instance, there's lesions around the ears or the eyes, for example, and these patients have a chronic rash that's lasting for more than a week, then actually this takes you away from a potential diagnosis of impetigo. And it's important to think about sending this patient to a clinician that may be more experienced in diagnosing skin ailments. Now, certain differential diagnoses include the following. The first one is, of course, allergic contact dermatitis. This is inflammation of the skin, often in response to some form of substance. When you're taking the history, the patient may be able to tell you that they've used a new detergent, some new perfume, a new washing up liquid as an example. And this sets off a particular immune response in the body, resulting in a skin eruption. Typically, these patients may have a reaction to things like gold or nickel and detergents, as we've explained. And this reaction may actually be restricted to a particular part of the body. So it may be, for example, the hands. So if a patient has been washing the dishes using some fairy liquid or new washing up liquid, then they may have allergic dermatitis of their hands and their fingers. It's a clinical diagnosis, but if there is some diagnostic uncertainty, patients are often referred on for something called patch testing. This is where particular patches of common substances and materials to which there is a reaction are applied on the skin of the patient to observe whether there is some form of reaction or not. The mainstay of management is, of course, to avoid contact with the offending substance or the offending item, but also to apply some treatment, including emollients, for example, antihistamines if patients are having significant and quite severe itching, and of course, other conservative options. Some patients may require, for example, some steroids, in which case they can either buy them over the counter through your advice as a pharmacist, or these patients may require something more stronger than hydrocortisone, in which case they will require prescription. Here are some examples of allergic contact dermatitis. You can see this is on darker skin. This is probably a reaction to the actual plastic that the slipper is made of. And as you can see, it's around where the patient's skin is in contact with. This is around the ears. This could be a reaction, for example, to glasses. So the glasses that I'm wearing are made of metal. For example, there could be some form of reaction to such substances and such materials. This is allergic contact dermatitis of the hands. You can see that there's quite significant excoriation of the skin for this patient, and the same applies with this patient as well, probably as a result of a slipper. Can be quite difficult and can be quite challenging to differentiate the last picture from psoriasis, but of course this would in principle require some form of review from a general practitioner. Cellulitis is your other differential. If you haven't seen cellulitis, I would suggest looking at some pictures. You can use references like dermnet.nz, which is a fantastic repository of dermatological images. Cellulitis is a soft tissue infection. It's caused by bacteria affecting the lower dermis and also the subcutaneous tissue, as well as an erythematous lesion that patients may have. This could start spreading. It can be quite painful. It can also be quite sore, and patients may feel quite unwell in of themselves because of the infection itself. The causative organisms are the same as impetigo, Staphylococcus aureus and pyogenes, and patients may be at risk of having cellulitis if there is a history of a skin break, some form of trauma, and once again, if they have some form of medical problems such as diabetes or even immunocompromise, or are on some medication that may cause some form of immunocompromise. It's a clinical diagnosis. Some patients may require further investigations like white blood cell count or, for example, even a swab. However, in the vast majority of patients, these patients are patients who may have clinical features, and that would suffice to make a diagnosis. Treatment includes giving patients antibiotics, including flucloxacillin, which can be given 500 milligrams 4 times a day for 5 to 7 days with a plan for further review and safety netting. This is a picture of cellulitis in darker skin. Once again, this is a patient who has had their area of cellulitis marked. It's a good idea to mark patients who have got cellulitis so that you can observe the efficiency or the effectiveness rather of the treatment that you give them. This is a patient with facial cellulitis. You can see that there is some form of extension of the cellulitis up towards the eyes. One has to be very careful because this could lead to orbital cellulitis, which requires intravenous antibiotics. But in the meantime, this patient has the characteristic erythema and swelling. And if you were probably to ask this patient, they'll probably confirm that there's some form of soreness to the site. Once again, on lighter skin this time, an area of cellulitis that's been demarcated. And once again, in an area which seems to be kind of the thigh area. So when we do have a patient who we think has impetigo, how do we decide whether they need antibiotics or not? Simply, we need to ask ourselves a few questions. Firstly, does the patient have less than 3 lesions or clusters present? And does the patient have localized non-bullous impetigo? If the answer to these two questions is yes, then these patients actually don't need an antibiotic ointment. Current NICE guidelines suggest that these patients can have hydrogen peroxide 1% cream for 5 days. Now, there are instances where hydrogen peroxide may not necessarily work, and we'll talk about these now, because the PGD pathway also suggests that you can use fusidic acid 20 milligrams cream for 5 days. Of course, subject to the inclusion criteria, which we've got as less than 3 lesions and also a non-bullous localized infection. Now, you may consider using fusidic acid, especially if hydrogen peroxide may not be suitable for the patient. They may have had it before and it may not necessarily have made a difference to their impetigo. Another unsuitability criteria is if the impetigo is quite close to the eyes, in which case hydrogen peroxide should not be used and fusidic acid is more safer. So fusidic acid is your second line option if required. If the symptoms do worsen rapidly, or the patient finds that the treatment has not helped at all, you can move from the first line to the second line, giving the patient a timeline of probably 3 to 5 days to see how it responds to the treatment. And if after the second line option, you feel that it hasn't helped at all, then this patient will require upstream referral to the general practitioner for further review. Now, if the patient has more than 4 lesions or clusters present, and the patient has widespread but non-bullous impetigo, so they have more widespread impetigo, but it's still non-bullous, which is a very important aspect to the inclusion criteria, of course, then this patient may require oral antibiotics, typically flucloxacin for 5 days, to ensure that the patient has adequate bioavailability of antibiotic to help fight a more widespread and more complicated infection. Of course, cater your dosage to pediatric patients who are over the age of 1, and the BNF, of course, allows you to do this based on the year that the patient is. If the patient, for example, is penicillin allergic, then the PGD also suggests alternatives. You can give clarithromycin for 5 days instead, once again at an adult dose of 250 milligrams twice a day. But of course, with children or younger patients, then this may require some form of changes, which you can refer to the BNF for. If the patient is pregnant, then of course they can be given some antibiotics too. Typically, clarithromycin or if clarithromycin may not necessarily be suitable for these patients, in which case patients are given erythromycin, which is from the same class as clarithromycin, for 5 days once again. And as always, please refer to the BNF for further referencing on dosages. If the symptoms worsen rapidly, which can worsen at any time, if there is spreading infection or spreading erythema, if the infections start to spread towards the eye or to the ears, for example, and if there are systemic features such as high temperatures, rigors, which is shaking, for example, like uncontrollable shaking, for instance, feeling very, very sick, then these patients need to be signposted either to go to their general practitioner or even 999 to accident and emergency if they've got features of sepsis. For all patients, the following advice stands. Patients should be advised as part of their consultation and their management plan to ensure good hygiene, to reduce the spread of the impetigo. And of course, patients should be instructed to complete the course of their antibiotics and how to take their antibiotics and when to take their antibiotic. Antibiotic education is very important and is all of our responsibilities because of antibiotic and antimicrobial resistance. Patients should be advised to use regular gentle cleansing, to not share towels, practicing good hand hygiene with ensuring that they're keeping their fingernails nice and clean. And of course, you can suggest covering the affected area with watertight dressing to prevent the spread. and also applying antiseptic cream a few times a day to help with the healing of the lesions. Patients with impetigo will require treatment with antibiotics, and therefore the parents of these patients may require some advice as to exclusion from schools. Currently, guidance is that they should be kept off school for 48 hours until the sores, the impetigo lesion, start to crust over and healed. Alternatively, if the patient has been on antibiotic treatment, topical or oral, for more than 48 hours, then they can go back to school, which of course will be music to the parents' ears. These are our references that we used for this particular presentation. There are lots of different resources that you can use to see and observe the pictures of patients with impetigo. As always, I want to try and end this particular presentation with some cases to help us think about some scenarios and perhaps help to inform our practice when we are assessing these patients in a pharmacy-first context. First and foremost, you have a 6-year-old patient who presents with 4 lesions with widespread non-bullous impetigo. He's penicillin allergic, so what is the most appropriate antibiotic to issue? So of course it's more than 4 lesions and he's penicillin allergic, so you can give them clarithromycin 250 milligrams twice a day for 5 days. Another case, a mother brings her 5-year-old child with 2 lesions this time, with some yellow crusting. Now this appeared 4 days ago and the mother has tried to wipe away the crusts. There is some mild itching. Think about this with regards to the PGD and pathway. What option would you do in terms of management? Now there's less than 2 lesions with some yellow crusting, so you can easily give them some hydrogen peroxide with some safety netting to help treat their localized impetigo. Thank you very much for attending this presentation on impetigo, hosted by myself, Dr. Mohammed Omaji, as part of Pareto Education. Please do check out our website, www.paretoeducation.co.uk/CPD, for some externally accredited CPD courses on a number of interesting and practice-focused areas in healthcare today. Lastly, please like, share, and subscribe to our YouTube channel. We have lots of useful content coming out on your screens on a weekly basis, and we'd love for you to share our work with others. Thank you very much and have a lovely remainder of your day.